I'm Judith Smith from the Nuffield Trust, and I'm chairing this next session with the pretty plain speaking title of Changing Services. And I was just reflecting that yesterday, if you can remember back to yesterday morning, which feels quite a while ago now, do you remember when David Dalton was with us, and Mary Dixon Woods, and others, and I think what stuck with me from that session was about the importance of actually sensing the problems, working out sometimes what's actually wrong, perhaps, or not working as well as it could with services. We talked about having the humility and determination to get on and sort those out within organisations. And then yesterday afternoon, I think it was early in the afternoon, we were thinking about the sheer complexity of the system that we've had bequeathed to us from the recent reforms, and then how difficult it can be to actually bring about significant strategic planning or change, just almost like that who's in charge sort of question. And this morning, with Gus O'Donnell and Sarah Pickup and Julian Legrand, we were exploring some of those issues about how those perhaps at the very centre of political power sometimes do make efforts to reform public services. But in this session, I think we really want to do some of the... I was in a session yesterday when we talked about lifting up the bonnet of organisations, but also just thinking really practically, how do we actually go about changing services, if indeed they need to be changed? And I think we need to bear in mind sometimes it's about just consolidating and sustaining really good services, but if they're not working, to change them in some way. So I'm going to have 4 different perspectives in this session to help us think about this. First of all, in just a moment, Tim Kelsey, who's National Director for Patients and Information at NHS England, is going to talk to us particularly about the role of patients and indeed data and how those can be used to really shift some of our thinking about how we change services. And I think, was it last year, Tim, you spoke to us on a similar theme, or 2 years ago? I can't remember. But again, I remember you were making that challenge. I think you're going to reflect a bit on where we've come to in that past year. Then we're going to hear from Michelle Mitchell of the MS, the Multiple Sclerosis Society. Michelle's the chief executive there. She's been there a relatively short time, before which she was for quite a long time the Director General at Age UK. But she's going to very much be reflecting on actually the role of charities, of patient organisations, what it feels like for them to both respond to the needs of their patient and carer groups, and to try and use that insight and intelligence to influence health and care and indeed other services. Then we'll hear from Tom Hughes-Hallett. Tom is chair of the Institute of Global Health Innovation at Imperial College. He's also recently been appointed, I think, as chair of the Chelsea and Westminster Hospital NHS Foundation Trust. But today he's going to particularly share with us work that he's been involved in through one of his other roles, which is about working with communities in Essex in quite different ways when thinking about how to change health and social care services. And then finally, we'll be hearing from Stephen Lewis from Saskatchewan in Canada. And Stephen's a professor of health policy at Simon Fraser University there. And he's going to challenge some of our thinking about generalism as opposed to specialism. How much perhaps are we organising our systems sometimes too much around perhaps the interests of getting ever more specialised, interesting services for doctors and others, as opposed to the needs of people with multimorbidity, which might need us to think quite differently about, say, what we sometimes call generalism. So looking through some different lenses at how services might be sustained or indeed improved and changed. So that's enough from me. I'm going to welcome Tim Kelsey to give us our opening presentation.
Thanks, Judith. Essentially my thesis is that the data revolution that will secure the future of the health service is already happening. And it's happening out there in a myriad of different ways. And the question for everyone in here is whether we obstruct it or whether we enable it. And if we don't start enabling it pretty quickly, I think the consequences for our health service will be tragic. But whatever we do, we're not going to stop the social movement that's already out there engulfing our public services. And we now need to address ourselves to that issue. And this came home to me, again, you know, it does, at the Expo last week. I don't know how many, sorry, this week, Christ, it's been a long couple of weeks. The Expo this week, where I was privileged enough to be one of the people handing out awards for excellence in participation to some amazing people who have just been getting on with it, frankly, without us providing them with much help at all, as we sit in rooms like this. And they've been getting on with taking better use of technology and data and just improving people's lives, you know, in small but really meaningful ways. And I just wanted to show you one example just before we get into the kind of the principles and the policy of one of the awards that was provided, because it just reminds us that we have to ourselves move quickly now to address ourselves to this social movement I think is already underway. So could I just ask if you could show the short clip? It's only very short, thanks.
At York Street Health Practice, we work with homeless people and asylum seekers. They often have quite chaotic and unpredictable lives. We've been using an approach to social value at the practice to take involvement mechanisms to our patients. This social value approach gets service users to tell their stories to our staff, to our partners and to our commissioners about the things that they value the most and the things that they value less so. An example of one of the things that were most important to them was an improved appointment system that improved accessibility for them. At the moment, our patients have to turn up on the day or phone up for an appointment, which can be quite disempowering. In reaction to this, we as a service have funded Google Nexus tablets, which are now used by our support workers and our partners out in the community, so that patients can get health and wellbeing information at any time they need it. And they can also register at our practice and book appointments online in their own time, which has led to a more empowering service for them.
Health and social inclusion are a key component of what we do at Leeds Community Healthcare. At York Street Health Practice, we're a service that works with homeless people, vulnerably housed people and people in the asylum system. Inclusion to us means bringing services to people and bringing people into services, opening doors for access and good care. The third way of inclusion for us is this project, which is a dynamic and creative project that allows service users across the city, some of the most vulnerable, needy, isolated people, to be able to book their own appointments, share issues, share ideas, share concerns with us, have an ongoing dialogue. It really starts to break down those walls that exist between health and services outside and place service users where they should be at the centre of their care.
So I think the message there is pretty clear, and all over the place that kind of thing is happening. Sam Everington was here yesterday. I'm sure he's told you about his amazing work on immunisation, but literally nothing more complex than data sharing between GP professionals has led to a sort of honourable competition in one of the most deprived parts of England, in which they frankly compete with each other to improve the way in which they're managing their patients. They share dashboards of data, and this has led to the improvement in immunisation rates in Tower Hamlets from somewhere in the low 70s to now 94%. So they are basically at herd immunity levels, and that's been largely, from their own perspective, driven by the simplest act of data sharing. So one of the things I in a way, it seems extraordinary we're even having the conversation, because actually we're having it, and the politicians are having it, and the media's having it, but out there people are just getting on with it. And I just want to, I think one of the things we do really badly is actually get out there, and I blame myself as much as anybody else, and what our job is to support those people. It is not to dictate to them. There are a few other things we do really badly, and again, because it's this group, and you know, we need to talk frankly to each other. I just want to rehearse through some of the other things we do really badly before I get on where I think we've got to over the last year. It is it is still unbelievable to me that we still can't count the number of people who are treated in this country with chemotherapy. We actually can't even count their number. We have no idea, largely, of the quality of service that they receive. That data set, what's called the SACT data set, which Mike Richards has been fighting for ages, is still not funded. We still have a relatively low level of compliance with provision of that sort of data from hospitals. That's my responsibility as much as anybody else's, but that's just a fragmentary example of an information infrastructure which is so far from fit for purpose it is frankly misleading for us to suggest that we can commission or provide services based on quality as things stand. And we'll get to care.data in a minute, but we ought to reflect on the fact that very little has meaningfully happened for the last 15 years, and we've all been in this room for the last 15 years having a conversation which hasn't, at this stage, taken us very far. So it's just a reflection. I'll get more optimistic in a minute. The other thing I find hard to believe, and I find shameful, if I'm being honest, is the degree to which our hospitals have not meaningfully adopted the digital opportunity really at all. And I was at a hospital not long ago, I'm not going to say which one, where the board decided against providing the most basic level of clinical record access to their clinicians because they were going to instead invest in the re-roofing of the ITU department. And the nature of the conversation that happened in that board told me that board, and I suspect a lot of other boards in our trusts, are not really capable of understanding the importance of having proper automation, proper customer service, and ultimately safe, high-quality services. To give you one example of that, at the moment, even though the evidence is irrefutable that electronic or digital tools to support stressed SHOs in the middle of the night providing prescriptions, it's irrefutable that digital tools massively reduce the error rate in hospital prescribing. Only 12% of hospitals have actually installed them. And obviously one of the big initiatives, which I'll come to in a minute, is trying to incentivize people to do it. But we should just reflect that we are doing a lot very, very badly, and the emphasis that's now being placed on technology and on patients. It was interesting to me, and again, I'm being really negative in a way, but interesting for me, and as a trustee of the Nuffield Trust, whose work I think is absolutely fantastic, that we don't have any, apart from Jeremy, I don't think we have any patient organisations represented in the room, though on Twitter as I came, oh sorry, and actually there's Macmillan there. But a relatively small number. But on Twitter yesterday, I did notice that there was a common theme emerging where people were talking about it more. We're talking about the importance of patient experience, and that in itself is a move, I think, in the right direction. But we should just be honest about the fact that I think we are not enabling, we're not aware enough of how we can be more enabling of people who are just getting it on with it out there. And obviously we're aware of this increasingly because every other part of our lives have adopted these sorts of strategies. You know, customer service in most other industries, and I know Jeremy talked about this a bit yesterday, has been transformed through both proper engagement with customers and understanding of what they actually want, customer insight, whatever language you want to use, but also, of course, through effective deployments of basic digital technologies. And although it is true that healthcare, for fundamental reasons, is not the same as retail or financial services, there is a lot we can learn from the degree to which costs have been saved and the customer experience improved through the use of low-cost, ubiquitous mobile technologies. One thing I would say on that, which I want just to get on the record, is although I believe profoundly that the analogy of the financial services sector, particularly the online retail financial services, is very, very important for us. And the degree to which it demonstrates that people, when they are confident about the security of their data, will trust organizations. And on that one, I think I may have said this last year, but on online financial services, we've gone from a situation where 14 years ago, nobody did it when it first launched, to a case now where we have 22 million adults in this country only using online banking. It's a quiet but profound social revolution of the sort we urgently need to see happen in healthcare. But there are some really big differences, and one of them is that citizens are not shareholders. And one of my big learnings over the whole care.data piece, but before that, and I've instinctively, I hope, been a champion of this from the first moment I got involved with Dr. Foster, is that citizens are not shareholders. They are citizens. The NHS is committed to universal healthcare at the point of delivery, and that's not the same as delivering a financial service. You're not in a market. We are here for everybody, and that's one of the reasons why care.data must be an opt-out scheme. I'll come back to that in a minute, because the NHS has to be able to plan its services in the interests of the whole community, and I'm sure everyone in this room share that view. So, a year on, we have still, and I think Jeremy has become almost more evangelistic than I am on some of these things, but the essential truth is that I think we've done some things in the last year which are going to change and better enable all those people who are just trying to get on with the rest of their lives while we have these conversations. And the first of those actually is care.data. So I'm obviously very happy to take questions on that, but as I'm pretty sure everyone in this room knows, I've been campaigning and arguing for the liberation of routine data in the NHS for 14 years or however long. And we have, existed on a thin sliver of hospital data, which produces, I think, some tremendous value, has produced tremendous value for us in improving quality in hospitals in a whole range of different ways. But we have no similar data for out-of-hospital care, nor indeed for most other care contexts. So the idea this would be the wrong thing to do is, in my view, profoundly wrong. So that's what care.data initially was the liberation of that out-of-hospital insight for the improvement and future planning of services. In the end, we have postponed, as everybody knows, the launch of care.data from March to the autumn because the debate we were having, in my view, is too important to rush. It's a weird decision to make, and I'm not a career civil servant, so perhaps that would explain it. But I really did listen to both the way in which there was just mass confusion about the sort of safeguards, and they clearly weren't good enough in the first place in relation to semi or partly or de-identified data. I'm not going to use the word pseudonymization. The safeguards weren't good enough. Neither was the clarity of the new right that we'd given the citizen, which is to opt out of these kinds of data flows, a right that's not contained in the legislation that underpins the recent reforms. So just important context here, Parliament spent a lot of time debating whether or not citizens should have the right to opt in or opt out of data being used for the improvement of health services, and came to the very conclusive view that it should not. And the Health and Social Care Act is clear on that. Despite that view, but that is the parliamentary context, and we do live in a democracy, we decided that it was the right thing to give people a de facto opt-out. And of course, that has caused quite a lot of confusion because it's unprecedented and a novel new right. So for a variety of reasons, and additionally, the public information campaign, although the team did a really excellent job within the kind of confines of what public services think is public information, in the context of the debate that we have to have about the rights of patients in the development of new health services, modern health services, it wasn't adequate. So for all those reasons, we've decided to delay the beginnings of the extraction to October, and we can discuss that. But I hope no one in this room would for a minute doubt the resolve that anybody, and that's right through the political hierarchy and across the NHS family, would doubt the resolve we've got to make this work successfully. It is not just a responsibility we have for ourselves, it's a responsibility I think we genuinely have for other generations, for future generations. It is an incredibly important... So I will be reaching out to all of you over the course of the next few weeks to seek your support in helping us do it better, to both explain it, though this is much more than just communications, but also to make sure that we do build a properly robust data infrastructure for the future of the NHS. And that's what care.data is about. So that's the first thing. Now, the data piece, building an intelligent health service is only partly about clinical routine or registry data. It's also fundamentally about a new genre of customer insight data, of data that tells us what the patient is experiencing. And of course, we've launched Friends and Family Test, and I think controversial in some quarters, that is itself the beginning of a social movement. And it was amazing to me yesterday, and I don't know if people are aware of this, that the most recent monthly results were published yesterday, that as of yesterday, the figures are that 1.8 million people have participated in the Friends and Family Initiative. In other words, rated their hospital and in many cases provided free text comments. Now, I don't know what the volume of traffic is over TripAdvisor. It's obviously much, much higher. But I just think that in 3 or 4 years' time, we will be reflecting on this kind of data being ubiquitous, fundamental to everything we do. And that's something that started this year. And the scale of it, I think, is much, much greater than I certainly personally it would be. So that's one reflection. The data revolution is already out there, but I think we are beginning to enable it as well. Another reflection is to do with the vital importance of giving people proper control over their own destiny and over their own data. So this is all about, the online records access commitments and so on and so forth. And again, from April, there is now a contractual obligation on GPs to provide their patients with online access to records when they wish it. That's a completely new context. It's not a DES, it is a contractual obligation, and actually the GP community has worked with us really well on that particular policy, and I think it will be confusing for people to start with. I think people will wonder what the point of it all is, but my prediction is that by the time we have this conference next year, there will be millions, a small number of millions of people who are actively engaged in downloading and getting value from their online records. And I think we'll feel in a very different place by that point. But again, that's something that's happening now, and I think it's a really important, and just a reflection there too, in this context of the outside world moving on regardless of what we do about our lives. We've got another interesting statistic, which is that NHS Choices now has around 40 million visits every month. And they're largely English people, and they are doing something which is giving them benefit because they keep on coming back. We need to find out a lot more about it, but it's a really astonishingly large number of people who are beginning to use that service. So there are a couple of other things. I'm not going to go on at them in any length, but I think the other key contributions we've made started this year: transparency. We have published a load more data in a whole variety of different characteristics, not dangerous data, but data about individual clinicians, and I think that's been a really fantastic collaboration with some of the colleges and other professional bodies. And we've also launched a whole program on interoperability. So going back to that shamefulness about the state of digital hospitals, we have now put about £1 billion worth of public capital on the table to try and drive and incentivize adoption of records. But I just wanted to finish, to go back to the beginning, to say that in the middle of all that, in my view, some of the most important things that we are collectively engaged in, and there are lots of people here from NHS England and other sort of associated bodies, is genuinely the commitment that both financially and from a policy perspective that's being made on participation. So whether it's personal health budgets, and that may have escaped people's notice, but we've just made a massive new commitment to personal health budgets, and you will see that start to become increasingly a visible program over the course of the next year. Or whether it's personalised care planning, and the Secretary of State in particular, but all NHS England absolutely has put such a massive priority in providing greater support for those with long-term conditions than others. And personalised care planning is at the heart of doing that. And personalised care planning is now a proper priority for NHS England. We are putting proper resources behind it. And I think that was a very important new development that took place over the last 12 months or so. So just finally, I think this is difficult stuff. It's very, very difficult stuff. It's tiring for me and for everyone else, but it's difficult, and but that shouldn't make us shy away from it. We are on the threshold of something fundamental. I think we've already started it. It may already be irreversible, but thank you for all your hard work. Thank you.
Thank you, Tim. Thank you for that. You've given us a whole range of ideas and themes to explore there, Tim. Not only the important issue about how data are used in the sense of that population level for this and for future generations, but I think particularly strongly about all that needs to be done about the involvement of people and patients in very different ways in how we enable them to access advice and care, or indeed around planning and holding their own budgets, as you just mentioned there. And I think, just again sticking with me in my mind, the clip from Leeds there about the taking quite a different approach, in a sense, the primary care going out there to be alongside people, but again using the technology in some different ways. So lots for us to think about there. That's incredibly helpful. Now, you made the challenge about patient organisations. Michelle is, of course, the Chief Executive of the MS Society and previously was at Age UK. So you're very welcome, Michelle. How does all of this seem at the moment from someone who's leading a patient and carer organisation?
Well, I just wanted to thank Tim for the presentation. I mean, I think the power of information and data for people and for organisations representing patients is incredibly important. I mean, one of the things at the MS Society that we've invested in is an MS register. So we have the largest patient-reported data set in the world for people with MS, and we're beginning to look at how we can use that to understand the patient experience, but also to help influence research, science, and the service design and improvement. So the power of information is absolutely critical. I was going to talk in detail about one of the programs that I've been involved with, but in fact I'm going to talk briefly about it at the end, because it feels to me, having been here for a day and a half now, there are a few other things that I want to say before I go on to that. One being, if you guys think it's complicated and a difficult arena to navigate, imagine if you're not part of the system. So charities who have a passionate belief and commitment about change, built on the experiences of the individuals, are also trying to navigate this system to ensure that they can transform and change as organisations and movements as well. One of the questions I think you were going to ask me was, what is the point I first want to make here? Well, the first point is there is only one or two people here from charities and patient organisations, and the people I know, the people with MS, would be wanting to use this opportunity to talk to such an influential audience about what their experience is and what they want to tell you. So I think that's something I wanted to kick off with. But also, a lot of the discussions are taking place, of course, with the change that you're experiencing, but charities are experiencing considerable change as well. Leading an organisation, I'm fortunate, my organisation's finances are holding up. We have a very loyal supporter and funder base, but on whole, charities are facing a 20% reduction in their income generation, that many of them have been slow to adapt to some of the changes in the commissioning environment and are seeing up to 60 and 70% of their contracts being reduced. So massive pressures on charities to be more accountable, to be better in tune with their beneficiaries, but also to face up and affect some of these changes at a time when there is significantly changing need. I mean, I was up in the Northwest earlier in the week, not at the Expo, but up in the Northwest, and I just want to talk about 3 people I met. One was a guy who was waiting for his ATOS appointment. He has remitting and relapsing MS. He can, on a good day, walk 25 to 30 metres. He's really, really worried about being better on the day he's going to be tested about whether he will be forced back into work. He's a policeman and told me he doesn't like to lie, so he's really having a moral question about that. But the welfare changes are having a big impact. There's also a carer I met who's cared now for 25 years for her husband, who has got progressive MS, has got increasing levels of accumulated disability. She's absolutely at her wit's end. She doesn't know how to cope. There isn't the support there beyond charities and self-help groups who in many ways are the last frontier for them in their communities. And the final person, I'm really going back to social care is a critical issue, and Sarah here talked this morning about social care, is you can see in the communities that social care is becoming more restricted for many people. Age UK put out a report today saying over a 10-year time frame, there's 800,000 fewer older people receiving social care. So charities at the front line are experiencing ever greater need at a time when their finances are challenged, and the emphasis and onus on them to transform is very strong. And the things that people tell us are the things that people tell you. There isn't a big dissonance here. I don't have a new message to tell you. People want to be engaged and have decision-making and involvement with their care and treatment. But it's not happening in so many areas. They want to have coordinated care, so they're not speaking to different professionals many times over. And they certainly don't want to go into hospital inappropriately. For people with MS, an MS nurse is particularly important in providing that access to specialist care and supporting the community. But it doesn't have to be, for other conditions, a specialist role like that. Volunteers can often perform that role also. People want help with self-management so they can make informed decisions, that they can shift their behaviour, that they can better take care of themselves. And of course, they want access to preventative services in the community, which keep them well, keep them fit, and keep them happy, keep them connected with other people. So all of these things are pretty important. The challenge is, though, in the environment we're facing, what does that mean for how we respond? How do we respond in terms of the services? So I would just finish with 2 examples. As a charity, you have to be clear on the outcomes you want to achieve. You also have to fund the activity that you want to deliver. That's hard in this environment. You have to go to places, not where people won't listen to you and the commissioning is weak and they don't really want you to be a partner in change. You have to focus your resource and go to the people who share your agenda. One of the things I did when I was at Age UK is run a pilot with our local Age UK in Cornwall and worked very closely with the clinical commissioning group there and also the local authority. And that took us, at the time, an organisation had provided services to older people for 60 years to think long and hard about what we were doing. We were providing services on information, services on emotional support, benefit take-up. Perhaps if the local authority was commissioning us, some exercise classes. All different strands of activity built around the funding that we could provide. To change our model of care at Age UK at the time, what we started with was saying, what does the individual want? What does the individual need? For the first time, we had a defined population. Rather than anybody coming through our doors, we said, no, we will focus particularly on those people that were most at risk of going into hospital inappropriately. And we worked with the GP surgeries in the area to have risk-stratified data, so we had a defined population. And then we employed, part paid, but also worked with volunteers to have a coordinating function for those individuals who were most at risk of inappropriate hospital admission. What happened by placing that individual within the district nursing team was quite transformational. We began to wrap around not only the clinical care through the GPs and others, through the nursing team, but also to say, what support do you need? Hooking people into the benefit advice that they needed, hooking them into self-help groups. With the pilot we ran, we found within a year we're making 1 to 4 savings and people are 20, 30% happier in terms of the quality of their life. We didn't change a lot, but those small changes were transformational. Where it doesn't work, and I'm picking up some of my experience at the MS Society, is where you go into communities and try to talk to commissioners, and they do not know their own data sets. They do not know that the main primary reason there's an inappropriate hospital admission for people with MS is urinary tract infection. And they're not interested because of the pressures they're under financially, huge amounts of change, in looking how you can redesign services to deliver better outcomes at lower cost. And so you have a hugely variable experience, but the optimism, I think, is something we need to finish with, because small changes can make absolutely transformational change to people's lives, and I believe strongly deliver higher quality at a lower cost. And you must see the charity sector as being a potential partner, but we are not you, and we do not understand the system in the way you do. And we need your help, support, collaboration and partnership so you can get the best out of us.
Thank you, Michelle. That was really powerful and interesting. And really strong resonances as well with the themes around data sets and again, but also that predictive work in Cornwall, really trying to understand what the needs are, but that partnership then of yourselves with the local professionals and managers and others. And I guess that sense as well of avoiding not just being driven by where the funding happens to be for what may be outdated or inappropriate services. And just not to forget, I think that really helpful insight as well into how it is for charities at the moment, that it's a time of austerity across the piece as well. So thank you for sharing that. Now, another thing you mentioned was actually about, I wrote it down here, people wanting engagement with their decision making and treatment, and that theme of engagement I think is one absolutely that Tom you're going to pick up for us about work you've been involved in Essex.
Thank you. Well, I'm a slightly unlikely anarchist in this respect, as I'll explain in a moment, but 15 months ago I set off on a really interesting journey, ably assisted by Martin Bardsley from the wonderful Nuffield Foundation, to look at a county of 1.7 million people who had had the courage to recognise that the system was no longer sustainable, either in healthcare or social care. And not just to recognise it, but to state that publicly. I think what they'd failed to realise was that it was probably the lack of sustainability was even closer than they predicted. At the time, they were worried about the financial year 2016-17, but I think many of us in this room now think the lack of sustainability is within 12 to 18 months. The principal task that I set out on was effectively to, I hate jargon, and my current bête noire word is integrate. It is very typical, I think, of policymakers to always use words that describe systems rather than people. And when I heard that Essex was applying to be one of the new integrated pilots, I prayed that they would fail. And indeed they did, and the feedback was that they were over-ambitious in what they were going for, which I thought was a fascinating piece of feedback. So what I decided to do was to spend a year of my life talking to citizens and do this completely bottom-up by holding focus groups right across an extraordinary county, ranging from some of the most... Clacton is one of the top 5 most deprived places in Britain, to some of the wealthier and leafier suburbs of Colchester. It might surprise you that what the citizens were saying was close the hospital. I held a focus group of 60 people in Clacton-on-Sea. I said there's a hospital exactly 45 minutes away in Ipswich. There's another one in Colchester 25 minutes away, and there's another one in Chelmsford 45 minutes away. What should we do? They said, well, close ours and reinvest that money, please, in community services and the local authority. Blindingly obvious, really. Of course, Mike Richards has done his very best to go about and actually achieve that. The poor old Colchester's now under careful supervision. But one of the things I really learned was in terms of change, don't underestimate what the citizen is up for. And I think we're very patronising about this often. I ran Marie Curie for 12 years, so I understand stakeholders as well. I met mothers who said, I do not understand, these were not wealthy people, why actually giving birth is funded by the state when I chose to get pregnant. While the man with dementia in the next door house to me, who is scarcely capable of looking after himself, has had his social care withdrawn from him because the value of his house lifts him above the threshold, even though he's got no cash. There was a third glorious moment when I presented to the people who were funding the commission. I arrived in a T-shirt which had written across it little acts of care, and local authority and health and wellbeing boards normally wear ties, and even the ladies. And Little Acts of Kindness is a charity that has been started as a direct result of the commission, because I've wandered around the county saying, you don't need permission to make change. No one can stop you making change. So I arrived to give my report on how I was getting on, and the council said, what's this T-shirt all about? I said, well, I've just launched this charity in Canvey Island. And they said, well, that's wonderful. What are they going to do? And I said, well, they're going to go round. They're going to identify the single most vulnerable people in their community as volunteers. And they're then going to help them receive health and social care and signpost them to the appropriate services. And if the state doesn't provide that service, they're going to find someone who does. They said, that's fantastic. I said, well, I just want to ask you a question. Are you worried about the fact you've now lost total control? You can't commission them because they don't need any money, and they certainly don't want it from you. You can't regulate them, and when someone dies as a result of their intervention, it may be rather embarrassing for you. And they paused. And then I quoted William Beveridge to them from 1942. The state, in organising security, should not stifle incentive, opportunity, and responsibility. In establishing a national minimum, it should leave room and encouragement for voluntary action by each individual to provide more than that minimum for himself and his family. Some of you may be familiar with the work of Ivan Illich. He can be controversial. I love him, actually. In 1975, he said that society which can reduce professional intervention to the minimum will provide the best conditions for healthcare. And actually, I believe passionately in that. And throughout the work I've done in Essex, which is now being implemented, I have used to the public the analogy of a car. And if you want to YouTube Hughes Hallett, you'll see the piece the BBC did. It's just about 3 minutes on this, but it's me driving my car into a garage. My children said it would have been better if I'd taken the mum's car, which is a Fiat 500, rather than my rather shiny Jaguar, which doesn't suit anarchists very well. But my basic principle was that as citizens, we're very happy to look after our car. We're very happy to take it in for an MOT. That's not a problem. We're very happy to make sure that we have AA coverage so that when we break down at 3 in the morning and need urgent care, we can access it. But the problem is we've been conned by the state since 1948 because the politicians keep telling us that healthcare is free at the point of delivery. What they don't say is the truth, which is that some healthcare is free at the point of delivery. And once you accept that not, and by the way, only if you need it. So having worked in the voluntary sector for 12 years, I know that there is this terrible confusion. And that is what the state has got to be honest about now. So the 2 core recommendations of our commission were, firstly, that there should be a new contract between the state and the citizen, where the state sets out honestly what it is going to make available. In 2011, having been asked by Andrew Lansley to write a commission on the financing of end-of-life care for adults and children, Professor Sir Alan Craft and I published a list of what the state should fund in end-of-life care and a list of what it shouldn't. And I was very unpopular with Cruz because I said that bereavement should not be funded by the state. Because if you fall off the operating table in a hip operation, you don't get bereavement support. So why should you get it just simply because you're going through the act of dying? It's controversial, but there isn't enough money to do everything, and we need to be honest about the basic clinical care that the state will fund, and then recognise that wonderful organisations like yours can help provide the rest with the astonishing amount of philanthropy that exists in this country. Don't let this lady depress you too much about philanthropy. It is still at very high levels, and I believe will grow. And that is why, very shortly, we're going to launch an international master's program at philanthropy inside our and my institute to make sure that we can really help the state by bringing philanthropy and healthcare much, much closer together. Citizens, on their part, have then got to take on the responsibility for their own healthcare. And no one in Essex voted against that. When I went round the whole of Essex talking about this, everyone said, we are responsible for our own healthcare. It's just that we've forgotten it. We think our GP is. The second part of this is really how we're going to mobilise communities to provide that support. And there are some fantastic examples of that going on elsewhere in the world, not least in the developing world. But in the developed world, I encourage you to look at the work of Professor Alex Haddad, who's become my great friend, and who runs the Institute of Innovation in Toronto. And he's doing work in Barranquilla in Colombia, and has already done it in the Basque Country, where one volunteer looks after 600 households and is effectively their public health and social care advisor and spots the vulnerable people. And in Barranquilla, each household in a city the same size as Essex has been given a tablet to enable them to put in their own data, which they own and input, which is they then share outwards to the clinicians and people who are providing it to them. So my last point, thank you, that's actually the chairman ringing me. My last point, I turned this off, it's miraculous, sorry. It's my wife. My last point is really to Tim, which is data is crucial. And this has been a big part of what we've said in Essex, which is unless we can uncomplicate the data message, because I think the problem with the data message, it's got so complex. There's research, there's integrating your data, my least favorite word, but I'm up for it with data. I think it's going to take a crisis to make this happen, and the crisis may happen in Essex. And I have warned Jeremy Hunt about this, I've warned Nick Seddon, I think he might even be in the room about this. At this moment in time, there is a time bomb ticking, which is that the fire service cannot receive from GPs the data about who is most likely to die in the event of a fire, because it's secondary data. So right now, the fire service want to monitor the people in Essex who are most likely to die in a fire. But all they get is sophisticated maps which show you where the most vulnerable people are, which I'm afraid, in my view, are a total waste of time. You've got to know who the individual person is. And that's why, in Essex, we're going to become anarchists, and we're going to do it ourselves.
Well, thank you for that. It's not very often I chair a session when we're talking about anarchy in quite such a upfront manner. But I'm particularly taken, Tom, from what you were saying about this. Don't underestimate what the citizens are up for. I think that was a really powerful message from that sustained work and focus group work, and actually just going out there and finding out what people actually want. And
don't tell us what to do. I mean, when Lamb stood up and announced that he was going to start creating these volunteer groups last summer, you could hear a pin drop in Essex. They were so angry. They said, we decide whether to create volunteer groups. We're not going to have the state telling us to do it.
Yeah. So thank you for that. And also, I think that point about little acts of kindness, because that resonates with what Michelle was saying about actually it's often relatively straightforward things, but it's the right things that people actually want that end up really making a difference for them. So I'll remember that as well. That was the logo on your T-shirt, I think, wasn't it?
I'll give you the T-shirt. It's a bit small for me.
As well.
You should have come in a T-shirt.
Yes, that's right. Perhaps all T-shirts next year at the summit. That would really show significant change, wouldn't it? That's right. Stephen, how does this look from the west of Canada, from all you've been hearing here? And I know you've been with us throughout the 2 days listening to our discussions. And just to say as well, Stephen's written a really interesting blog on the Guardian website about generalism and specialism. And I know you were talking about that earlier this week at the London School of Hygiene. But just your reflections, just to start drawing some of this together.
Well, I have the unenviable job of coming across the pond and trying to give you advice on what to do. It's likely to be wrong, and on the theory that you'll forgive me for being wrong if I'm also brief, I'm going to give you some snippets of what I think I'm hearing. It was a wonderful coincidence that Andy Burnham talked about generalism yesterday too, as a possible solution. I'm not so sure we have a consensus on what generalism means, but I think following from your point as well, the whole notion that while we have a narrative of scarcity in healthcare, there's also a growing reality of superabundance when you read the literature that healthcare is a risk factor, and specialization in particular is a risk factor. So when I heard the story about the woman in Oxfordshire who had 6 and then 9 consultations with consultants in a short period of time, I think her risks of harm go up exponentially. And moreover, I also think you're exactly right that the presumption that if you give patients power and give citizens power that they will be infinitely demanding is exactly wrong.
Yeah.
I think they are very restrained in their expectations. And when you ask them what makes sense, as in my own city, if you ask the citizens, do we need a children's hospital in Saskatoon? The answer would be no. If you ask the pediatricians and their philanthropic friends who wanted one, the answer was yes. Guess what we're getting? We're getting a new children's hospital. So I do think that the generalism of 2 sorts is one of the keys to the solution here. And the generalism repatriating some care from specialists and making primary care more robust in its capabilities, a little less technology dependent, a little more integrated in a human sense, in the diagnostic sense, would do everybody a lot of good. And I think you've actually gone farther in that direction in England than we have in Canada, so I salute you for that. But there's a second part of it, which is about what I would call the hubris of the healthcare technology paradigm, that we're going to solve every conceivable human problem by doing better science. I mean, I wish it were true, frankly. I mean, I'm not anti-science at all. It would be a wonderful thing if we could get personalized medicine and magic bullets. The promise has always out-delivered what we've gotten, and I think a whole conversation about truth and restraint would be in order. And that leads to a couple of other things that I think are important that I heard. The primary care system, in a nutshell, should be organized and designed around exactly the kind of people that Sarah Pickup was talking about. If a system is good enough to have a comprehensive, coordinated, yet simplified and easy to navigate journey for people like that, it's going to be good enough for the rest of us. We tend to organize it for the rest of us because most systems, because the middle class has all the political power, are organized for the middle class. But frankly, we're not the problem, unless we're unlucky. The problem is the chronically ill, the frail elderly, and marginalized people with complex disorders, some of which originate in mental health. So try to be good enough for them, and you'll be fine for the rest. There's a lot of conversation about data, and again, you guys have so much more data than we do. We're an international embarrassment in terms of the timeliness and quality and relevance of our data. But I would say, and this I think falls from Tim Ferriss's presentation yesterday, ultimately healthcare is very transactional, and clinicians are the ones who are going to improve it or not improve it. Right now, most clinicians' view is we need to survive the data. They don't embrace the data. What we want is clinicians who are data users, data seekers, and who use data for quality improvement. And while this will get me kicked out of the Health Services Research Union, I care less about standardization of data than actionability of data. And I don't think they're mutually exclusive. But if people are going to use data, we're going to have to make it extremely easy for a typical clinician in any discipline to actually get his or her hands on it, use it as a habit of practice, and generate quality improvement strategies daily with it. And I think that is the future that is really going to drive this forward, which will lead to another, I think, mini revolution, which is a fundamental relook at the division of labor. In Canada, everybody is working to the bottom of their scope of practice. It's built into the system's incentive and into the regulatory framework, frankly, imposed by guilds. We need to crack this open. If you want to lower unit costs, and if you want to make people happier in the workplace, they need to work at the top of their scope of practice. And it's not just doctors and nurses. It's nurses and licensed practical nurses. It's licensed practical nurses and healthcare aides, et cetera, et cetera. We have medicalized so much social care that it is needlessly expensive and not very effective. And I think there's a tremendous opportunity to revisit that. And I think most healthcare organizations would be up for it if we can also guarantee people job security. People will not undertake a genuine rethink and relook about what they're doing if they think their jobs are at risk. So I think that's the trade-off you make. You say you've got a job, you've got a position, it may not be the same job in the same place 10 years from now, but we are not throwing you out on the street in order for the system to get better. And I think that's a deal I would make. And finally, and I think as important as ever in the short run, give clinical groups a mandate to address variation. Don't tell them how they have to address it. Don't leap to conclusions about whether the variation bespeaks under, over, or misuse of services, but just say, look, variation is the enemy of quality. Variation is rampant. You collectively need to get your heads around it, and we will leave it to you to solve it, supported by whatever tools we can give you, and we'll be very happy to give you data, support, tools, QI, the whole business. But it is your obligation. And I guarantee you, if you get clinicians to take this seriously, you will eliminate waste and inappropriateness faster than any other strategy we can impose by policy. So that's all I got.